Good morning, ladies and gentlemen, and welcome to this next in the Wellbeing of Women Charities webinar series. And this one is entitled Talking Menopause. And I'm joined today by Lisa Snowdon, who's a very well-known broadcaster and recently has also become a writer, with which she's going to tell us possibly about her new debut book, which I think has got the most exciting title, Getting Started, Lessons in Life, Love and the Menopause. That came out in May. And also Dr Naomi Potter, who is an NHS doctor and GP who's had a specialist interest in women's health for many, many years. And has also done much education work and also co-authored the book Menopausing with Davina McCall. So I couldn't have wished for better panelists to help me address this thing about talking menopause. So I just wanted you to understand as the audience that Wellbeing of Women is the only UK charity which is working in women's health throughout the whole of the life course, literally from cradle to grave. And we funded lots of projects on menopause, and most recently on menopause in the workplace, which I feel very strongly about because I want to carry on working in my menopausal years and remain as healthy as possible. So Dr. Claire Hardy in the University of Lancaster is doing some work developing a toolkit to help organisations support staff impacted by menopause symptoms. And 2 years ago, we launched the Menopause Workplace Pledge. I can't believe it's 2 years ago. It seems like just last year, but with that, we asked employers to commit to supporting staff throughout the menopause and improving the work environment for women affected by the problem. And that's been featured in national media, and we've now got 2,600 organisations or employers who've joined. And you can go on to the Wellbeing of Women website if you'd like more details. We could never say no to somebody else who'd like to join us. And last year, we launched our campaign, Let's Chat Menopause, all about normalising conversations around the menopause and discussing how it impacts on all other areas of life, including films with celebrities, including Lisa and her partner George, and other wonderful menopause advocates such as Penny Lancaster, Carolyn Harris, the MP, Michelle Griffith-Robinson, Dr Nigat Arif and Zoe Hardman. So I think most people joining us today understand about the housekeeping rules of a Zoom meeting. We're recording this. Please use the chat function for comments and questions. We're going to encourage you to put your questions in throughout the discussions now, and then towards the end, about 15 minutes before the end, at about 1:45, I will turn to the audience questions. But I'm going to start now, if I may, by thanking our sponsors, who are the Financial Services Compensation Scheme and Bolt Burden Kemp, for sponsoring this webinar and allowing this to happen. So without further ado, let me first of all introduce Dr. Naomi Potter. She's going to just quickly tell us in a few chosen sentences or quick sentences, the context for joining us on this webinar and what drives her to want to promote the menopause. So Naomi, over to you, and then I'll turn to Lisa.
Thank you, Lesley. Lovely to see you. So my name is Dr Naomi Potter, and I'm a British Menopause Society accredited specialist, and I spend all of my time nowadays either seeing patients with menopausal symptoms or trying to educate as best I can women across the world really into how to recognise their menopausal symptoms and how to access the help that they may need.
Fabulous. And I think that's the access, isn't it? It's the access. It's so important. So what we've got to start by doing is ensuring that women understand what they can do to help themselves, not to actually have to do it for themselves, but understand who they need to go to and that they don't need to suffer. Because as I often say, you can have the most wonderful policies and the most wonderful health services, but if women don't know how to go about, don't know what's normal and what's abnormal and where to go. So I see these webinars often as a signposting system so that more and more women will get to where they need to access the help they need so they can just get on with their lives. Now, over to you, Lisa. I introduced you before as a broadcaster and now a writer. But just give us a brief snapshot before we talk about your own personal journey.
So thank you for having me. It's lovely to be here, Lesley. I'm passionate about talking about the menopause. I'm postmenopausal now at 51. And the reason I'm so passionate about talking about the menopause and the signs and the symptoms and perimenopause and what to look out for is because 10 years ago, when I first entered my perimenopausal years, I didn't know what was happening to me. So it's all about awareness. It's about looking out for the changes, being prepared and understanding what's happening to our bodies, and then knowing where to go to get the help and having, just being educated and having an informed decision about which route you want to go down.
Yes, and I think that's so important, because I'm always saying in my role as a Women's Health Ambassador for England, and also as the chair of Wellbeing of Women, the great thing about giving information to women is that they don't keep it to themselves. They immediately follow the good advice, and then they go and tell everybody else about it. So I think by giving them that information and getting the signposting right, we're going to have hundreds and hundreds of thousands of ambassadors for women's health running around the country. So Lisa, now I'd like to, if I may, and thank you for agreeing to do this, turn to you to talk about your experience of the menopause and how it came about that you were feeling it. I mean, you've given us a quick snippet about how you didn't know what was happening, and I think that's that certainly resonates with me. I remember one of my daughters, and I have twin daughters who are now nearly 31, and one of them saying to me something rather, and I said, well, why have you told me that? That that's not true, and I know it's not true. And she said to me, because you're so scary at the moment, Mum. And I thought, oh my God, and here am I, reproductive gynecologist with a menopause clinic, and I hadn't recognised it in myself. So that's my opener. Over to you.
Yeah, well, similar. So it's a really weird time. I think back to 10 years ago, and that was when my first symptoms started to kind of show themselves. And initially it was anxiety, it was low mood, it was feeling very over emotional. I'd cry at the drop of a hat. Things that I would usually do day to day, I found near impossible. I would feel like I was at the bottom of a mountain and I just couldn't even leave the house. So it was really challenging, and I didn't understand what that was. I didn't know it was perimenopause. Certainly that word 10 years ago wasn't on my radar at all. I'd never been taught it. I'd never been spoken about in school. It was always periods and pregnancy, and then that was kind of it, sort of left to our own devices, like what happens next. So for about the next 6-7 years, I struggled through tons of crippling different symptoms. It moved from anxiety and depression and low mood and over emotional kind of feelings of feeling lost and helpless into my cycles changing quite dramatically. So going from a 28-day to a 10-day cycle to then nothing at all to then bleeding really heavily. And then also debilitating pain associated with the bleeds as well. Again, didn't put 2 and 2 together, still didn't think, these are my hormones that are playing havoc in my body. And then the symptoms it shape shifts a little bit. So things kind of move, and it's hard to work out what's happening to you, because then I started to get really angry, like you said, Lesley. These rages, I was really mean, I was snappy, my fuse was really short, I was horrible to be around, and I could feel like this anger bubbling up in me, which is really out of character. And then I started to get the hot flushes, and I think because that's more of a common symptom that you do associate with menopause, I think that's when I was a bit like, hot flushes, night sweats. But of course not everybody has those typical symptoms, and we know now that there's about 60 and counting, and that estrogen is responsible for so many of those, or lack of estrogen rather, for so many of those symptoms. So I look back and I think, well, actually, did I have that bout of vertigo when I was in my early 40s? Was that perhaps also perimenopause? So so I kind of tried to navigate it for the last sort of 8 years, and then I found Dr. Potter, who came to the rescue, and I haven't looked back. It's been amazing connecting with Naomi and learning about what's happening to my body. And then obviously we do our chats every week with our community on our Instagram, and it's just been so fantastic to share what's happened to me, to get the advice and knowledge from Naomi, and to share it with our community. Like you said, Lesley, people want the information, they want the knowledge, and once they get it, they spread the word. And I think we just need to continue talking about menopause and perimenopause, so women aren't lost, they aren't alone, they don't want to leave their jobs or leave their partners or just hibernate. They can get a handle on what's happening to them sooner and get back into the real world and jump into their new power, which is how I feel now.
It is. It's incredibly powerful, isn't it? When you feel you've got your life back, when you think
Yeah.
you've been on the brink. I think all of us. And there's some lovely comments in the chat. Great to be here. Look at those 3 wonderful, beautiful, powerful women hosting this webinar. Oh, I love that too. Thank you, Kirsty. you can come again. Anyway, lots of comments about great to be here, and we're thrilled to be joining. So that's lovely. So I suppose then what we have to ask is, what was the advice that Naomi gave you?
Naomi was like, why aren't you on estrogen? What is happening? And I probably should caveat by saying I had gone to see a couple of doctors prior to that. And I think my first encounter with the doctor was in my early 40s. So I was about 42 when I was brave enough to kind of bite the bullet and try and go to the doctors and find out what was happening to me. But what I didn't do is I didn't arm myself with a list of potentially my symptoms or things that I was struggling with. What I did was I sat opposite the doctor and just had a breakdown. I just burst into tears and I was sobbing. And so the poor guy literally had to like pick me off of the floor. And, you know, he just said, I think you perhaps need antidepressants. And I said, I don't think it's that. I really don't think it's that. I think there's something else happening. I'm not usually like this. I don't feel like myself anymore. But he did prescribe me antidepressants, and I just knew it wasn't what I should be taking, but I did take them for a short while. And then I decided to come off of them. Obviously, I weaned myself off safely. And, you know, there is a place for antidepressants. And I think perhaps, you know, they do sometimes sit alongside HRT, don't they? And I think, you know, it's not a weakness to ask for help. So I'm not saying that nobody should take antidepressants. I just knew that that wasn't what I needed at that time. So then I kind of left the doctors, took the antidepressants for a short while, came off of them, and then I just tried to go it alone for a bit and just try and hack my health and do the things that I knew to make me feel better, try and eliminate stress, try and exercise a little bit more. But alongside the cycles changing, my weight started to really I got put on about 3 stone when I was at my heaviest, which was tricky as well, and that's been tricky to try and keep it off as well, but that's a whole nother topic. So the weight gain was challenging, especially because I do lots of TV and things like that, but I think for any woman the weight gain is always very challenging. When you go into your wardrobe and nothing fits you, it's really hard on your confidence. And then you've got the brain fog to contend with, and then you've just, all of that just really impacts your confidence. So going to work is really tricky. So then I went to 2 different doctors, and again, didn't get the right HRT, unfortunately. So it was about 6 or 7 years of navigating it through 3 different doctors. And then I met Naomi, and she said, what have the doctors prescribed you? And they'd only prescribed me with a progesterone cream, never estrogen. So Naomi was like, you need estrogen. That's what you need. And I was like, give it to me now. So I was, I tried the estrogen, and within about a month, 6 weeks, I started to feel so much better. But it is a 360 approach to wellness. It's not just HRT, it's lifestyle changes and understanding that you are getting older and that we can't do everything we used to do. And we need to take responsibility for our health as well.
I want to pick up on the weight thing, because it's, you know, in my capacity as a gynecologist, women are always saying, oh, I don't want to do that, or I don't want to go on hormones because it'll make me put on weight. But I think what's important, and you've highlighted it beautifully, Lisa, is that actually this is a middle life issue when your metabolism starts to slow down a bit, and you just have to do more to keep yourself fitter, don't you? But you didn't find, though, that going onto the hormones or onto the estrogen actually made you put on more weight. It gave you the zip and the viv to actually get on and do something about your weight gain.
Absolutely, Lesley. It gave me, I started sleeping better, which is obviously what we need, because on those sleepless nights when I was absolutely soaking wet and then shivering cold and then soaking wet again through the heat, and I was up peeing every hour, I was not getting good quality sleep. So the next day, perhaps I had 2 coffees instead of 1. So then my adrenal and my adrenaline would just be going, and I think, you know, that is so hard for us, and causes inflammation in the body. You know, I was snacking because I was hungry, because I wasn't sleeping.
Snacking, keep yourself going. Yes, I
yeah.
The junior doctor doing very long on-call weekends, and often in the morning thinking, well, what do I do now? Do I eat 2 Mars bars? Because or do I just starve myself or what? Yeah, absolutely. So really important. So, but I want to get the message out there that, you know, it's not, the hormones aren't going to make you fat. It's actually a bit about your metabolic rate going down. So you need to do more about well-being, to include exercise, be more careful with your diet. Actually going on to HRT doesn't necessarily make you overweight. I mean, it's a really important point. So thank you.
It gives you that impetus to work out. It gives you more energy to get to the gym, to move. Right. I think, you know, for us ladies, we do need to do weight-bearing exercises. So strength training, we need to really, you know, help with our bone density and our muscle mass. As you said, the metabolism slows down. So anything that can kind of try and keep that metabolism ticking over, and things like running is great, but that doesn't build muscle. So when you build muscle, that helps your metabolism to keep moving, and then it helps to increase your bone density as well. But it is about food. It is about watching what we eat. We can no longer eat all of the pizzas and the burgers, not every night anyway. You can have it as a treat every now and then, but it is smaller portions, really nutritious food, movement every day. Movement is medicine. And yes, in combination with HRT, it's been brilliant for me.
And so, important point to mention, it's not that we're discouraging people from running, but that's not what's going to help with your muscle mass. You need to lift some weights or just do some squats every day, all those things. Okay, great. So Naomi, coming on to you, obviously, I think most people on this platform will think that they know about the menopause, but do you want to just summarize what menopause is and what are the most common symptoms that you see in women who come to seek your advice?
So as we get older, our ovaries stop working in the same way that they used to when we were younger, and then eventually they stop producing eggs completely. And the point that happens is the menopause. You only know that you're in the menopause 12 months after you've had your last period. So you have to wait for that date to come and go before you know that you're postmenopausal. But the time leading up to that, which is often the time where you have the most turbulent symptoms, is the perimenopause, where your ovaries are working a bit, but they're not working in the way that they used to, and that's what gives the symptoms. And the symptoms can vary enormously from person to person, and even within a person, and they can change, and they can come and go, and that's what is so confusing to so many women. They almost feel like they have, you know, a couple of months worth of symptoms, and then they feel better, that they kind of imagined what had happened in those preceding few months. And you know, they might have their debilitating symptoms and they book a GP's appointment, but by the time that GP's appointment's come round, they're actually feeling okay, and then they cancel the appointment, and you can end up feeling a bit of a fraud. But because estrogen is responsible for so much, there are just so many symptoms, and it's not always apparent that it's the perimenopause that's giving you those symptoms. So it can be so wide ranging, literally from the top of your head to the tips of your toes, in terms of the kind of reach of those symptoms. And it's often misdiagnosed. So particularly the less well-known symptoms. So for example, tinnitus or palpitations, the mental health symptoms, so low mood or tearfulness or anxiety. There's so many symptoms, and that are relatively easily treated as well. And I think that's partly what the well-being of women's doing today, isn't it? Is just kind of spreading that message so that women know what's happening to them, or if it's not them, they can recognise it in a friend or a loved one, and then they can then go and get the appropriate help.
Exactly, and that's why I'm so pleased that there are men on the platform too. I know we've got 3 female presenters, but there's men on the platform too, because I think they're part of the solution too. I was very, very excited when I was invited to go and give Sir Lindsay Hoyle, who's the male leader of the House of Commons, a framed certificate of the menopause workplace pledge that I was talking about earlier. And he gave a very moving talk about how he knew nothing about this until his wife really struggled with her menopause, and as a result of that, this time last year he was determined that the House of Commons was going to be a menopause friendly, and of course that viewpoint coming from a senior, well-respected male made it so much easier for women to get what they needed in that particular environment. So it's so important, as you say, all the men today will be able to translate what they've heard to their loved ones, even if it's not now, it'll be sometime in the future. So that's really good. Now, you've told us a bit about the common symptoms and how we can recognise them. So now we need to think about some treatments and lifestyle changes. I'm really going to take home your lovely quote, Lisa, 360-degree approach to general health and lifestyle. And lots of people in the chat are picking up on that too. But What other treatments would you suggest, Naomi, that they start with, and lifestyle changes? Say I was at visit 1 to come and see you, what would you be saying?
So I think one of the issues is that women use certain tools to self-medicate their menopause symptoms, and it's unfortunate that the tools that they use are often making their symptoms worse. So it's identifying those, and it's not rocket science. It's things like alcohol and sugar and not exercising, and sleep. And diet, and so and coffee. They keep going on. So all the things that actually. So some women kind of look at me when I talk to them about it, and then but those are my treats. And I try and reframe it with them. It's like, well, they're your treats because your life is not comfortable, and you are using those to make it more comfortable. But if you didn't have those symptoms, then you would be much more comfortable, and you wouldn't be reliant on them. And you can get into this vicious cycle whereby you have your symptoms that might disrupt your sleep, and so you get up in the morning because you've got to, and you have a couple of cups of coffee a day to pep you up, or you might have a Mars bar because you're feeling so lacking in energy, you look for anything, and then by the end of the day you're so wired that there's no way that you're going to sleep, so you have half a bottle of wine or a bottle of wine, and then you sleep really poorly because you're anxious because of the alcohol, and you might still have symptoms that are waking you up, and you just get into this vicious cycle where the next morning all you can do is have a couple of cups of coffee a day, and then you're too knackered in the day to do any exercise, and it all feeds in to that same vicious cycle that can be incredibly hard to get out of, because if you've still got those underlying symptoms, even if you stop all of those tools, you need something to help you with those. And I think it's just helping women to see that in themselves, so that sometimes, like so often I say, about how many cups of coffee are you drinking a day, and they're like 2 or 3, and it's like, it's a powerful drug, caffeine. It's not, it is not to be underestimated. Yeah. And then if these women go away and they just have, even without anything else, even without HRT or any other medications, if they make those changes, some of them come back to me and they're just like, wow, I cannot believe how powerful caffeine was. I can't believe how much I was drinking alcohol for all the wrong reasons. So those are the main things. And then if you get somebody out of that and they're able to do some movement, finding the right kind of exercise that works for you is the most important thing. There is no way that the majority of women are going to be able to go from doing nothing to running a marathon, and nor should they. Mm-hmm. And it probably isn't going to do them any good. It's about finding something that you enjoy, because it's your kind of self-care time. That's going to be beneficial. You're going to get moving, you're going to be out in nature, hopefully, and that can make a massive difference. And again, with diet, so if you're knackered and you're craving sugar, then you reach for the wrong foods, and then you're not getting the nutrients that you need. And it's about educating yourself and reframing, what is going to nourish me, what is going to make me feel better throughout the day, rather than a quick hit now. All those things are amazingly helpful.
What about lovely point you've made, though, about, sorry to interrupt you, Lisa. I think a lovely point you've made about how you're snacking and you're doing those things because you're trying to treat yourself to help with the symptoms, and therefore it's not that you're a bad person or you've got no discipline, but you're trying to cope, because that's what women do. They're trying to get on with their life, don't they? Whatever traumas are hitting them, they try and get through it. So I think the audience, I want them to take away that this is because you need a bit of help. And that those sorts of things are really important to understand, as opposed to the sort of the self-blame and self-loathing bit that sometimes we go and do, don't we? Lisa, you were going to say.
I was just going to say some other kind of more homeopathic, sort of more alternative treatments like reflexology or cognitive behavioral therapy. Those kind of treatments are really good too, right? If you're not wanting to go down the HRT route, or if you can't take HRT.
That's DBT is clinically proven, especially for women who can't take HRT. It's very useful for symptom control.
And absolutely. And then reflexology, anything that just can kind of calm you down and slow the system down, and just try and just.
Naomi, what other natural remedies do you take? We'll come back to those who can't take HRT, but some women say they don't want to take hormones. So what would be the natural remedies that you would recommend them to try?
So there are herbal remedies, so things that you can buy from your local health food shop. Some of them are more proven than others, and some of them have slight concerns over particular safety angles. But there's things like black cohosh, St. John's wort, red clover. All of them have a role and have a place. But it's really important to speak to your pharmacist or your doctor about what you're going to take if you're going to buy one of these products, because they are pharmacokinetically active. It's not they're not necessarily, just because they're herbal, able to be used by everybody. And then, as well as the lifestyle things that we've mentioned, there is the more holistic therapies, so as well as CBT and reflexology and acupuncture. There is a whole host of kind of platforms out there, kind of fitness platforms, headspace and mindfulness. There's all sorts of things that you can find the most appropriate to you. And then there's the non-hormonal medicines that we use for targeted symptom control. Again, some women just may not want to use HRT, some women can't use HRT. And so there's certain types of antidepressants that we use in specific doses that can be used. There's something called oxybutynin and clonidine that we use for specific symptoms.
Would you like to just talk about some of those non-hormonal medications, because I think women would like to look at that. I'm trying to cast through the questions, but they're coming up. There's 37 ones I haven't got to so far. I'm now at number 70. So lots of questions. So clonidine and oxybutynin, that will just give us a feel for that, will you?
So if you have what we call vasomotor symptoms, so hot flushes and night sweats that can be massively debilitating in themselves, and they also have physiological consequences for having them. So it's not just about having the symptom itself, but they can be predictive of worsening health in the future. The first line treatment for those is HRT. Mm-hmm. But there's a few subgroups of women who can't take HRT. So, for example, if you've had breast cancer or if you've had endometrial cancer, and so some women like to look for specific medicines that they can use to target those treatments. And those are two groups of medicines that we use, and they can be very effective at stopping those symptoms. And you can discuss those with your GP, which would be the most appropriate to you. And the same with some types of antidepressants, depending on some other medications that you might be using. They can also be very helpful, particularly with the low mood that's associated with menopausal symptoms. And again, it's not a failure or anything kind of negative, towards you not being able to cope with your symptoms. It's just simply, you have a symptom and this is a way of controlling that symptom.
Exactly. I want to make just one quick comment, if I may. There was a lady who was putting one of the first comments in the chat about how she wasn't having hot flushes and a night sweat. She was feeling cold. And if that lady's still on the platform, can I suggest that you go and get your thyroid checked? Because that's the other thing that often happens at about this time. If your thyroid goes wrong, either it becomes overactive or underactive, that can be a confusing, produce symptoms that may be confusing as well. So important. And also a comment about vitamin B12, Naomi. One lady saying she can't sleep unless she takes her vitamin B12. So do you want to make a comment about vitamins? Because I mean, I have patients who tell me about the vitamins that help them do this, that, or the other. Almost every day I go to clinic. But so have you got some thoughts, vitamin gurus, please, for both of you?
I like my vitamins, so I like my vitamins.
Lisa has bottles and bottles of things, lotions and potions and sprays and things.
One of them.
So I think it very much depends on the individual. If you have a diet that for whatever reason is restricted, then there are definitely roles for vitamin replacements. So particularly vitamin B12 or folate, sometimes magnesium, vitamin D, sometimes a general multivitamin, sometimes iron. It depends on what your own intake is. You have to be a bit careful about it. So firstly, there is just a very basic cost that can be associated with some of these vitamins and supplements. they can be massively expensive. It's not just a, you know, a coffee a day, but I mean, they can cost hundreds and hundreds of pounds. And with a lot of them, you are consuming them and just weeing them out. Some of them, though, if you take too much of them, can cause problems. You know, they can cause kidney problems, liver problems, so you have to be careful. So I would say that vitamins definitely have a role, particularly if you are in a position whereby you either have limited absorption or limited intake. But if you are concerned, it's best to discuss with somebody that knows you and what you're taking, and just to make sure that what you're doing is firstly worth it from a cost point of view, and secondly is going to be beneficial, and thirdly is not going to be harmful.
Exactly. And the number of times women will pull out these bottles and tubes and blister packets and say, oh, look at these. And I say, how much did they cost you? And they tell me an eye-watering figure. And I said, but it's no different from the one in Boots. Go and buy the generic form from Boots.
Yeah.
Not antivitamins, but, you know, you don't have to spend a fortune. So thank you for making that point. Really, really helpful.
There are just on the flip side, you know, I know that Lisa gets a lot of relief from just having a few. They're almost kind of comforters, aren't they?
Yeah, my nighttime ritual is taking my magnesium, which I really find to help calm me down at the end of the day. And if you have got the energy to get to a class or go for a walk, or, you know, and you have a little bit of soreness in your muscles, if you're just starting off, I find that magnesium really helps with muscle recovery as well. I find it kind of, for me, I know that you're the doctor, when it lowers my temperature at night, I don't know, I feel like maybe it's placebo and it lowers my temperature, so then I find that I can slip into a sleep more easily. And but vitamin D and
placebo
vitamin D.
effect, the placebo effect is powerful, and if you have something that's not going to cause you any harm, it's not breaking the bank, then, you know, I don't see.
My magnesium is from a high street store.
your moon spray, you know,
I've got aura sprays and aromatherapy, all those things just that make you feel so
Well, my particular thing is taking zinc every day, because I think that zinc is a coenzyme, or rather it's one of the metals that goes into many coenzymes. And I worked with an anaesthetist for years and years who was convinced that the only reason she never got a cold was because she took double zinc every day. I just throw that in. So what can we do then what can we advise all these women that they can do? So many have been saying in the chat that they've been gone along to their GP, they've had problems. So what practical advice can we give them about where they can access support for their symptoms and to help get the right recipe, if you like, for themselves? What would you both say?
We always say that obviously go to your GP, but armed with a list of what you're feeling, what you're going through. Maybe write your cycle down, maybe just write down everything you've been feeling, everything you've been struggling with, so that when you've got that very short appointment time, you're able to communicate, to articulate what's happening to you, rather than, like I did, just burst into tears and not communicate what was happening to me. So then at least you're like, what about this? He's like, okay, what about this? We'll check your thyroid, like you said, Lesley. What about this? What about this? And so you can rule out anything that might be more sinister potentially if you're having heart palpitations or anything like that. But equally, you're seen with your list and you're able to get all your symptoms across. And then it's usually, if it's a handful of symptoms and you're over 45, it's usually a no-brainer that this is perimenopause. But I do appreciate it's really hard to get a doctor's appointment. It's really hard to be seen. It's really hard to be heard. And I don't think doctors automatically assume that it is hormonal, right?
Well, I think it's changing. I can't see the chat, but are people saying that they are struggling to get kind of appropriate even now?
Well, they're saying that so often they've been to the doctor and they've been told that they should have antidepressants or that there was nothing wrong. So, but I think that's getting better. I mean, the awareness campaign, thank goodness for Davina McCall and Carolyn Harris, that would be that's really helped quite a lot. But I think the other thing is that I think we need to tell our audience as well about all the fantastic websites you can go to. I mean, and if you've logged onto this, then you know how to get onto the Wellbeing of Women website, and there's lots of stuff that you can do there. Go onto the NHS website, which I'm happy to tell you is an awful lot better than it was 18 months ago.
I was going to say.
It's really is getting better, and I think that's good. And then there's so many, if you just Google menopause charities or menopause support groups, you will find lots of those too. Really, really helpful. Now, I want to ask a slightly different question, because a couple of ladies have said they're in the perimenopausal years, they haven't got to the the 12-month interval of being period free to make the final diagnosis, can they get pregnant and should they be using contraception? And I think that's a really, really important practical point. So, Naomi, do you want to start off with that one? I've got my own views too.
Yes, I had a patient in the last week or so who has was very much perimenopausal and 47 and had had her coil removed. And I said, well, what are you doing for contraception? Assuming she would say, oh, my husband had a vasectomy. And she said, well, I was just told that I didn't need contraception anymore.
Oh my gosh. A little surprise at 48.
Well, exactly,
yes.
Yeah.
So a couple of things I want to then emphasize. So not having a period does not mean that you're not fertile. And taking hormone replacement therapy also doesn't mean that you can't conceive a pregnancy. So if you're having regular sex, and I hope you all are, because I think it's the thing that most human beings want to do, then make sure that if you haven't got a formal diagnosis of being actually menopausal with hormone levels, FSH and LH really, really high, that you use some form of contraception. I mean, my ideal recommendation would be to get a Mirena fitted, because then you can use it to counteract the endometrial thickening. And for most women, it really works very, very well. But really important, so don't get caught out with an unplanned pregnancy, because it's the sort of thing that's going to make you really fed up at that particular stage in your life. So what else have we got here? Well, we've got lots of people also talking about the fact, or lots of women, I should say.
Sorry to see.
What?
I've just seen Claire's message. I wish I was having a good sex life. Claire's just real quick.
Okay, all right then. Well, I'm just hoping it. You know, I'm just wishing you all the best, all of you. But I think it's really quite important to remember. And if you are having vaginal discomfort, then I think even if you've had breast cancer, it's perfectly okay to be using vaginal estrogen cream to lubricate the tissues. And I think that's really important, because very, very little gets absorbed. But quite a few women have said that they've got estrogen positive breast cancer and they're on tamoxifen. What can they do to help? Not just with their symptoms, but let's add in and with their sex life. So what would you say, Naomi? Because this is a question that, you know, women say, I ask them a question about it rather, and they'll say, ooh, and it's almost that they'd almost look around and say as if anyone's listening. But actually, we've got to get all these things talked about too, haven't we?
Absolutely, absolutely. So the first thing is and what most women are very, very comfortable doing is using non-hormonal products. So lubricants and moisturizers can very much help. So you use a moisturizer like you would moisturize your face or your body every day. It's no different. It doesn't, there's no risk associated. No, it's not massively glamorous, but apart from that, it's, you know, there's no, and it's a bit of a hassle. There's no downside to using those. And the same with using a good quality lubricant and making sure that the products that you choose are not going to cause more irritation. So you can see some women that come and see me are like, well, I thought I was doing the right thing, and I've been to my local chemist and I bought a whole load of exciting looking products, and then they end up very, very uncomfortable with thrush, and it can make things worse. So just is very much worth checking that what the product that you are using is the right pH and it's physiologically balanced. And then, yes, it's not very often that somebody cannot use a vaginal estrogen product. And the information leaflet that comes with those products is incredibly scary, and it really should be largely ignored. It talks about risks of clots and using it with migraines and the risk of breast cancer, and all of those it's just been pulled from other old material, and it's yeah. Not relevant. Yeah. And the difference that having a well estrogenized urogenital tract can make for most women is just phenomenal. So yes, it can very much help with sex, but also in a much wider context. So just general day-to-day discomfort, but also urinary tract infections and urinary symptoms that have significant morbidity and even mortality associated with them.
Thank you. And Naomi, lots and lots of questions in the chat about bladder symptoms. And the first thing I do when women come and talk to me about their irritable bladder or their having to, finding themselves restricted because they don't know where the nearest loo is, so they don't want to go out, is to put them onto vaginal estrogen, and then also some systemic estrogen as well. But I just wanted to reassure everybody on the platform that if you're using transdermal, so patches or gels, i.e. via the skin, you get the maximum benefit as it all goes into your body before it gets broken down. And that really is not associated with an increase in blood clots, which is really important. So if you're using a transdermal, so something on your skin, either gel or patches, that doesn't increase your risk. So if you go along to the GP, I'm going to get into trouble here, aren't I? When they tell you you can't because you've got a risk of blood clots or heart disease, you can tell them very firmly that not if they're using transdermal. And if you had a Mirena coil, you wouldn't be able to, or Utrogestan tablets, which is often very helpful, isn't it, for women who are not sleeping well, because they tend to be a bit make you a little bit soporific. So if you take your Utrogestan, which is a natural progestin at night, that can also be really helpful. So I think a lot of it is really about crafting the remedies to that individual woman and her symptoms. And I would say as well, and I'd be interested in Lisa's comments about this, when women say, oh, well, that didn't suit me, I'd say, yeah, but HRT and other remedies, a bit like sweets in a sweet shop, there's all sorts of different colours and sizes and shapes. So try one, try another one, and
yeah,
around until you've got something. Any thoughts about that, Lisa? Because
yeah, absolutely.
One?
Not one size fits all at all when it comes to taking your HRT. Some people don't absorb the gel. Some people don't like the gel. I particularly like the spray. That works for me. Some people want a patch. Maybe that's easier to just change it twice a week. You don't have to think about it every day. But I like my spray, and I like my Utrogestan pill as well. And I've added a little testosterone into the mix. But like so many ladies on this chat, I still don't have that much of a libido either. So don't be disheartened if you are on testosterone and it hasn't really made you, because I don't know, it hasn't made me extremely rampant, which is a bit of a shame, but I'm still waiting. I'm still waiting for that libido to come and find me.
Okay. So can I turn to you, Naomi, and tell us and the platform a little bit about the different ways that you can access testosterone if you feel that you'd like to try that, and also about the problems of prescribing, because I think that's often, GPs may often say, oh, well, I can't do that because it's off license, etc., etc. So practical tips to if somebody here wants to try that out.
So the guidelines for testosterone prescribing and use have changed slightly in the last 6 months, a year, and it's become a little bit more conservative. But at the moment, the guidelines are that if you have a persistently low libido and you have a low testosterone and you have been on HRT estrogen, then using testosterone may help. And the problem that we are faced with in the UK is that there is no female testosterone product that is licensed for use on the NHS. So if you go to your GP, there's kind of more than one obstacle, because firstly, they're going to have to prescribe you, if this is appropriate to you, a male product. And when they put that product into their computer, it's going to say that it's not allowed to be prescribed because it's off license. And so if you don't have a GP that is experienced in understanding testosterone prescribing, you may fall at that hurdle, because they won't be able to prescribe you the female products. It's only available privately, and that GP might not be able to prescribe you the male product. If you can get testosterone from your GP, then it needs it can be very effective at helping a low libido, but it's not always. And it can take a good 3 or even 6 months to work, and you need to have your testosterone levels monitored, because we need to make sure that those replacement doses remain or keep your testosterone within that normal physiological range for a woman.
But it helps with other things too, right? It helps sometimes with brain fog a little bit if the estrogen isn't helping completely. I found it helped to give me that little bit of extra
Well, I think it probably does.
Going to the gym, I feel like it gives me a bit more oomph.
It's the data. So the data that is available at the moment, we can't use anecdotal data to say something for certain.
Right.
So we don't have the data to link testosterone use with things like cognitive improvement at the moment. I am a firm believer that it does, and it's just a question of finding, you know, of getting that data, because you see what happens to men if they have their testosterone blocked, and it's not just that they lose their sex drive. It seems like this hormone affects, you know, lots of systems in the same way that estrogen does, and we didn't know about that until recently. So I think it's a very emerging
That's
area.
a very important point to make, because one of the members of the audience who's obviously a male, and talking about debunking the male menopause myth, and saying that the production of testosterone and other hormones declines over a period of years, and the consequences aren't necessarily clear. So just so we can do that and make sure that we get more men to join our webinars going forward on all sorts of topics on women's health, do you want to make a quick comment about that? Because testosterone levels do fall, don't they, in men? And what other symptoms may they be experiencing?
Well, that's not my area of expertise, Lesley. But yes, they do. But I don't know how predictably they fall. I mean, in women they fall, and they fall unpredictably. So I suspect that it's similar in men. But we do know that, you know, men remain fertile. So, you know, a lot of men remain fertile into their much older years. But I think it's just an area where there has been very minimal research, and there is very minimal understanding. But just because that, it doesn't mean it's not true, which is the same with women and testosterone. Well, it's the same as so much of the menopause, isn't it? Just because we don't have the data does not mean that it's not real or true.
Yes, exactly. Now, I'd like to come back to a point that Mandy Harling made a little while ago, and saying, you know, she had such troubles accessing help in her GP practice. And her question is, can more be done via women's health hubs, perhaps, to enable training, information for staff within practices? I can answer that one, Mandy, because what I'm really excited about, it's only taken us a year to get to this point, is that we've now got the women's health hubs, and we got 25 million from the Department of Health and Social Care, which isn't a lot of money, but it means that every one of the 42 integrated care systems, the new collections across the regions in England, are going to be, have been given a chunk of that money to set up a women's health hub. And one of the things that we've really prioritised in that are the commonest things that happen to women that they tell us they have difficulties accessing. And the first, of course, is problem periods, heavy periods, painful periods, and the appallingly difficult problems that have emerged out of getting contraception, and also menopause management. So yes, the women's health hubs, they're going to be a very, very easy win for improving menopause. So look out, you know, perhaps go along, talk to your primary care network and say, where's the women's health hub in my region? I'm absolutely convinced that once we demonstrate how much money we can save in the health service by you, Lisa, or me, Lesley, or you, Naomi, going to one place and getting your smear and your mammogram and your problem periods or your menopause or your contraception or whatever all sorted out, you know, maybe a longer appointment than normally, but, you know, rather than going 4 different days, having 4 days of work, or having to arrange for your elderly parents to be looked after 4 times instead of 1. I mean, it's a no-brainer, isn't it?
Absolutely.
We've got to do that. And I just find it extraordinary that our political masters don't get this. But anyway, they are now starting to get it. So I'm very pleased about that. So yes, health hubs are definitely on the map. And I'm hoping that every one of these integrated care systems, when they see how efficient it is, and how these women just disappear from these waiting lists because they've been sorted out, that they will actually start to scale up, because it will be, you know, foolish not to get more of the same. Now, I want to just ask both of you, for perhaps you have different takes, one as a doctor and one as a user. How can we talk to friends and family and colleagues about menopause? What have you found to be the most effective way to communicate and to improve understanding?
Gosh, I mean, I talk about it all the time. I'm just really open and honest.
That was just me that I talked about.
No, if anybody, I speak to people and I'm like, I think she needs estrogen. I think she's going through perimenopause. I think she needs help. Like, I'm just constantly like, there's still so many women just don't know what's happening to them. And I see women in their 40s and 50s, and I'm like, I just have to ask them that, how are you coping? Like, what's going on? And, you know, I just see so many women stretch beyond their means. So I just continue to talk about it. Talk about it to men, talk about it to my nieces and nephews. I just want that conversation to get louder and louder, and so that everybody understands and can look out for their friends, for their loved ones, for their work colleagues, and lend, you know, an ear, an arm, a cuddle, if anybody is struggling, and just to try and offer that advice. And so I just think I just will keep talking about it openly and honestly and without any shame, and so that it's no longer taboo. And that's kind of all I've done and all I'll continue to do.
Absolutely. And I think it's so important because, you know, there is an inevitability about every woman becoming menopausal if she lives to the age of 50 or so. Some will come earlier, some will go a little bit later, but it's an inevitability. So as I often say in my ambassador role, look, these are predictable things. I can't predict if Naomi is going to get some awful gastrointestinal problem or a particular cancer at a certain stage, but I can predict that she's going to have 12 periods a year for nearly 40 years of her life. I can also predict that it's very unlikely that she'd be pregnant for more than about 2 or 3 years of her life, and then there's another 80 something to look after. So, I mean, we've really got to turn the focus, you know, and get away from that whole Handmaid's Tale about, you know, women are incubators. They've got lives to lead and we need to get on with them. So lots of questions here about, will we get a recording? Yes, you'll find tomorrow that the wonderful Wellbeing of Women team will have loaded this all up, including all the naughty things we've said, onto YouTube. So you'll be able to access it, Mal. The link will go out tomorrow. And yes, please, because I need to show my 40-year-old daughter. Yes, I expect that's a really good idea. You can show everybody, show your boss as well, particularly if he's male. And I think that's really, really exciting that we've got so much enthusiasm. I mean, I can't actually answer all these questions because there's hundreds of them now. And I can't even offer to answer them all and send that with the recording because there aren't enough hours left in my day today. But I think it's really great that we've had so much enthusiasm. So what would you say, Naomi, about the talking? What do you find are the best ways to get people to engage and understand what women are experiencing?
I mean, I talk about it all the time as well, and people aren't hesitant to kind of talk to me about it. But I think one of the things that may be a barrier is the feeling that if somebody suggests that you may be perimenopausal, it's not an insult. It's not a, you know, it's yes, simply offering advice, and it's always well-meaning. It's not designed to be derogatory in any way. And it's changing. I think that is definitely changing. But I mean, I say it to some of my children sometimes if they've been on the receiving end of you know, something that they've not expected from maybe a midlife woman. And it's true. I mean, honestly, it may be the perimenopause, and if you haven't noticed it in yourself as a woman, then it sometimes needs somebody to point it out to you. And that shouldn't be an insult, and it shouldn't be the brunt of jokes, because it's a very real thing and women suffer for years with it. And I think now that it's becoming more mainstream, it's brilliant, but it's still not mainstream enough. It's still not spoken about without stigma at all. So I think we're getting there.
We are getting there, slowly.
Yes. And this is not an illness, and it isn't something to be ashamed of, as you've both beautifully commented. And I think, you know, that's why I keep going on about it's an inevitability, but I'm going to live for longer, probably menopausal, than I was reproductive, because our life expectancy is so much longer now. So it's really important that women don't get sort of put on the scrap heap when they hit 50.
Absolutely. Hence the title of my book, Lesley, Just Getting Started. Let me slip that one in.
Well, I would quite agree. Please get her book. Is it out in the shops now? I need to get a copy. I need you to sign my copy when I
will. I'll sign and send.
Great. So I think that's really important. Now I want to make a comment about Myrena's, because a couple of things have come back. As I said, the chat is flashing like this in front of me. So, forgive me, anyone who, if I've missed your point. But there have been concerns about Myrena's and absorption of estrogen, rather progesterone that isn't natural progesterone. But I just want to reassure everybody that the reason why the Myrena's are so successful at combating heavy periods during your menstrual years and so good at protecting the womb lining from getting thick, is because the Mirena sits in the cavity of the womb, and the womb wall is so thick that virtually nothing gets absorbed. So even if you've had cancer and you know need for some reason to have HRT, or you'll be allowed to have some transdermal HRT, the Mirena is perfectly safe. I did a little trial last year with women who were saying, oh yes, but it'll make me put on weight, and in fact it didn't. And it was often it was the women actually thinking, oh well, I'll snack a little bit more, as we were saying earlier. Sometimes we, you know, when we have something that we put into our bodies, we then think that gives us the all clear to break the rules about other things. So I think that's really important. And then what would you say to women, because there have been a lot of questions about breast cancer, what would you say to women about that? Because I mean, I've got a rather wonderful oncologist, because I've had breast cancer, who just says, oh well, Lesley, you're not going to die of breast cancer. You're much more likely, because I'm quite slim and I'm a certain age now, to get problems with osteoporosis or heart disease. And so she's perfectly happy for me to have low dose patches and a Mirena coil. But would you like to make a comment about that, Naomi? I don't want to be irresponsible here, but I think it's important that if women are really suffering with tamoxifen and also with anastrozole and all of the, you know, all of the other ones, the aromatase inhibitors, what would you advise them to do?
It's very individual. I think it's so perspective plays a big part. Breast cancer history, you know, how recently, whether you've got active breast cancer, whether you've got it's been a long time since you've had your diagnosis, what your individual fear factors are, how bad your symptoms are. And so we see a lot of women who have a past history of breast cancer in my clinic, and we have an extremely individual conversation with all of them, and we incorporate advice from their oncologists, and we come up with a plan together. So we do have some women who've had a history of estrogen receptor positive breast cancer who use low dose estrogen HRT, but it's a big conversation, and you know, it's quality of life, symptom control, longevity, you know, risk of recurrence, all of those things are discussed at length and repeatedly discussed. So, you know, from one year to the next, to the next, to the next, and you come up with a plan together. But I think patient opinion and desire is so important. You know, you can have women who are utterly crippled by their symptoms and their life literally is not worth living. And you make a decision based on all of those things.
Exactly. So if you've been told you can't have something because of a particular problem you've got, go back and ask the questions again, you know, and explain the severity of your symptoms. And actually, I think you need to do a risk analysis, don't you? I did mine, and I thought, oh, I've got more problems with becoming osteoporotic and of whatever than I have of anything else. And I think that's it. The individual approach is really, really important.
The other thing is that oncologists are typically not keen on the use of hormones, but an oncologist's mission in life is to prevent breast cancer from coming back at all costs. And menopause doctors are very keen on symptom control, and it's very much a collaborative approach. And often that if you just have the oncologist speaking to the menopause team, they then become much more comfortable about it. And so if there's anybody watching here who's oncologist who says you must not have hormones, then ask for a referral to a menopause centre, and then we can connect the dots and have conversations that involve everybody and come up with a plan that suits the patient rather than the fear of the oncologist.
Very much so. I couldn't agree with you more, because I've now, when I'm dealing with someone who's had breast cancer or any other hormone related problem, I always say, would you like me to copy in your oncologist? So I'm almost like taking the responsibility away, or rather taking it on myself. Yeah. The number of times that those oncologists have then contacted me and said, well, do you really think this is a good idea? And then being very, very supportive. And I now get quite a lot of breast surgeons sending me patients to talk to, particularly after, you know, DCIS and things like that. So fantastic. Now I'm going to have to bring this to a close, because otherwise I'll get shouted at by the Wellbeing of Women platform staff, because we've got to finish. I expect lots of people have got to get back to work and things. This is why we host these at this time of the day, is that, you know, most people can manage to get to a screen or get to their phone for a little bit of quietness. There have been, well, you can see the chat for yourselves, I hope. Lisa and Naomi, that people are over the moon about how informative this has been. When's the next one going to be? This has been so helpful. Once a month would be fabulous. I'm not sure we can all manage once a month, but we'll see what we can do, because this is really important. So thank you again to Lisa Snowdon and Dr. Naomi Potter, and thank you to the Wellbeing team. Thank you to our wonderfully responsive and interactive audience, and particularly to the men who've come along. I'm thinking great things that you're going to be doing for us, and we'll organise some more webinars. And please, please, please go onto the Wellbeing of Women website, and if you can donate to the charity, you can help get more educational materials, more webinars funded. And if you can't do that personally, ask your employer to do it too, and join the Menopause Employment Programme, and sign up to the Menopause Workplace Pledge. So every single person on this platform, all those hundreds and hundreds of people, every one of you can do something to make sure that this sort of work with well-being of women and your health and well-being for the future are better. So I really, really look forward to it. The link for the website is on the chat now, for those of you in the audience. And I have a nasty feeling, Naomi and Lisa, that our team are going to be on the chat to you, or on the phone and the email before the end of the week, to book you for another session, because I think we could probably do it again. I've got lots more questions I could ask you. So thank you again. And with that, I'm going to say happy rest of the Wednesday today. Bye-bye.
Bye.
Bye.